pushed. And Lisa, it's all yours.
Great. Good afternoon. My name is Lisa Villarruel. I'm the Medical Director for the Division of Public Health Preparedness at the Arizona Department of Health Services, and the Medical Director for the Health Emergency Operations Center for the COVID-19 response. Presenting here with me today are Charles Larson. He is the Initial Project Manager for the Arizona Surge Line at ADHS, Terry Mullins, Chief of EMS and Trauma Systems here at ADHS, and Kathy McKenna, Chief of Healthcare Institution Licensing at ADHS. It is our pleasure to have a chance to present this new Arizona resource to you. We ask that you submit your questions through the chat box, and at the end, we will get to as many as we can. I can go to the next slide. Here is what we plan on covering today, the background and the reasons why we created the Arizona Surge Line, and then more into what it actually does and how it does it, and how your particular facility can participate. Next slide. Okay, to start with background, next slide. As you're aware, Arizona, and I'm sure you all, have been preparing for a surge in hospital admissions due to COVID-19. And we've seen hospital systems and facilities collaborating in an unprecedented way to address this anticipated surge. And actually, the Surge Line is a product of that collaboration. Next slide. Okay, so to talk a little bit about triage levels, next slide. Of course, things change throughout a pandemic, and that's what we're preparing for, starting with triage level 1, which is conventional levels of care or normal care, and then into triage level 2 or contingency levels. That's when you see hospitals at maximum bed capacity and resources are becoming scarcer, and hospital staff absenteeism is 20 to 30%. And then on to triage level 3, which is crisis levels. And this is when hospitals are out of resources, staff absenteeism is high, we're out of transport, and there are altered standards of care. So in terms of situational awareness, currently Arizona is considered to be operating at triage level 1 for conventional, and we are preparing for triage level 2, contingency, and 3, crisis. I will say that it is unclear when elevation or movement to the next level will be occurring, as that is impacted by social mitigation and these other public health strategies. A secondary surge due to COVID-19 is highly likely. We don't know when that would be, but it's likely, and we do expect to see more strain on our hospital systems when it coincides with influenza season. Next slide. Moving on to the structure of the Surge Line, next slide. In light of an anticipated hospital surge, the idea here was to create a 24/7 toll-free call line, like a one-stop call line that could help expedite transfers from one facility to another, to higher levels of care, lower levels of care, and just to do so through a centralized platform to speed that process and to equalize the hospital burden across the state, so that no one hospital is reaching level 2 or contingency, for example, before another one. Next slide. This is just another way of saying that. It's our mission, these 3 bullet points here, and we wish to do so with efficiency, consistency, and ethical consideration. Next slide. This resource, this call line, is meant to be used statewide. It is a service made available to private, public, and federal facilities. It is to be used only for the transfer of presumed or confirmed COVID-19 patients, and it is expected to only be active for the duration of the COVID-19 emergency. Next slide. The call service is a free service that is going to be maintained by the Arizona Department of Health Services, and it would be free to healthcare facilities to utilize. It does have a number of process flows. Those were based on protocols that were jointly developed by an Arizona work group made up of hospital transfer centers and chief medical officers. Next slide. So this is the actual core of the service. There are these 4 key components. Number 1, to expedite patient transfer to a higher level of care when indicated. Number 2 is to expedite patient transfer to a lower level of care when indicated. Number 3 is to provide a safety net for interfacility transport when resources become scarce. And number 4 is to provide critical care and palliative care consultation services. Next slide. So if we're going to get into each of these in more detail, when we say the surge line will expedite patient transfer to a higher level of care, we're really, we mean expediting transfer to a facility that has a higher relative capacity. So for example, they have med surge beds or ICU beds or ventilators that are available. Next slide. When we say that the surge line will expedite patient transfers to a lower level of care when clinically indicated, we're basically talking about helping with patient disposition, either to an alternate care site, to a homeless shelter, or a step-down unit. Often patients, we know, stay in the hospital simply due to disposition and coordination challenges, and we'd like to utilize the surge line to help open up those hospital beds in times of a surge. Next slide. The third component of the surge line is to act as a safety net for the interfacility transport of presumed or confirmed COVID-19 patients when there are challenges with transport. You know, with the numbers that we are currently right now seeing, and we're aware of the surge capacity of our current patient transport system, we don't anticipate needing this very frequently, but we are preparing just the same. With the activation of the surge line, all hospitals and transport systems should continue to arrange and okay, this is the friendly reminder, of course, to mute your lines. Okay, so the point here is that hospitals and transport systems need to just keep doing their regular protocols and arranging and managing transport as per normal. The point of the surge line is just to act as a safety net to help arrange that transport, or we can also request federal transport resources when challenges with transport arises. Again, we do find this to be an important part of the surge line because if there are beds available or ventilators available, but there's no transport to them, then we are not able to optimize patient placement and care. Next slide. The fourth component is a nice one. It's one that we also haven't seen implemented in other states, and that's if a patient cannot be transferred and or transported because of a lack of beds or resources or transport, or if the time to expected transport is over 60 minutes, then the sending physician will be offered a real-time critical care or palliative care consultation with an Arizona specialist to help them manage their patient in place. Next slide. Now, the data that we are going to use to make decisions about patient transfer will be based on near real-time bed and ventilator surveillance. The concept here is to maintain surveillance of bed and ventilator availability statewide, so we see where the availability is, we see which hospitals are filling faster than others, and that helps us place a patient accordingly. We are starting out using EM resource, and then we are transitioning into a more automatic bed board up through the use of central logic and the HIE. Next slide. So the overall process flow then is the following. The originating facility calls the surge line. The surge line performs a minimum clinical intake. Then the surge line agent looks at the state bed board and determines the most appropriate destination healthcare system in Arizona. Then they'll patch that first caller through to the destination transfer center that's been selected. And then the destination transfer center does what they always do, which is their intake, getting their physician approval, bed placement, and arranges transport just like normal. Next slide. This process flow changes, I guess it more augments slightly when we are dealing with greater surge and perhaps triage protocols that are being implemented, meaning we're getting into levels 2 and 3, contingency levels and crisis levels. So if a destination facility declines the transfer of a patient due to their triage protocols, there will be an appeals process. And second, if a patient is unable to be transferred or transported, the requesting provider will be offered that real-time critical care or palliative care consultation. Next slide. The surge line staff is going to be made up of EMCTs and dispatchers located here in Arizona. The consulting physicians also come from Arizona and are critical care and palliative care specialists. Next slide. In terms of how these algorithms choose the appropriate destination facility for patient placement, there are several criteria that are being used to determine the appropriate destination facility, including comparative available beds, where the last 10 patients have been placed, and at least for level 1 conventional, where we are right now, there will be consideration given to the facility that is closest to the sending location. Next slide. Hospital participation has been rather great, actually, so far. Only one hospital so far has declined to participate. All others, including most federal facilities, have been participatory. If there is a hospital that's currently on the webinar with us and is not aware of this surge line, please email us at surgeline@azdhs.gov and we can send you a startup packet with the data requirements and collaboration principles. We do ask a few things of participants, hopefully all of which have a $0 direct cost. Number one, first, all requests that your facility places for a COVID-19 transfer should go through the Arizona surge line. Number two, all requests your facility receives for a COVID-19 transfer should be redirected to the Arizona surge line if it didn't come from them originally. Number three, we ask that your facility maintains bed surveillance, either agree to a 30-minute turnaround time to bed placement from the time that the Arizona surge line first calls. Next slide. This is what is included in the hospital startup packet. This is not posted online, and it will not be posted online, but it is available to be emailed out. Hopefully, most hospitals that are on this call have already received it. Next slide. In case there's any EMS or CONs that are on this particular webinar, I know there's some questions about this, and I just want to clarify. Number one, the surge line honors existing transportation agreements. Number two, it is not going to interfere with 911 calls or any other pre-hospital transportation, only for inter-facility transfers. It's not for transfers from, home to ED. And hopefully they don't feel too much of a change from the existence of the surge line other than potentially an increase in inter-facility transportation because we're potentially moving people around to higher levels of care, lower levels of care, et cetera. Next slide. This is a new system. We've never tried this before in Arizona. So we have a couple clarifications and frequently asked questions that we've gotten. Number one, the surge line works with the transfer centers and transfer coordinators and with EMS and patient transport companies. It doesn't change those arrangements, contracts, or protocols. Point number two is that the surge line works and interacts with public, private, and nearly all federal healthcare facilities. However, it does not work or interact with the public. This is a facility call line. And number three, the surge line number will not be posted publicly in an attempt to protect the line. But all hospitals, transfer centers, hospital alliances, and hospital associations do have this number. Next slide. So in terms of evaluating this new service, next slide, evaluations are going to be administered to the surge line staff, the physician consultants, and to the hospital transfer centers. Analytics will also be created looking at the surge line, including the number of transfers, from what hospitals, to what hospitals, and the turnaround time. These will be collected on a regular basis. Again, this is a new service here. If it works and if this is successful, it could potentially be used for the next event, be it a nuclear event, a pandemic event, fire, mass casualty, anything that would create a hospital surge. Next slide. Okay, as for next steps, next slide. So here's the rollout of the 4 key components. Number one, expediting patient transfer to a higher level of care is already done. It is up and running. People are being transferred as we speak, so please utilize the line. The safety net and the consultation service should be up within the next few weeks, and then trailing a week or two behind that is point number two, or key component number 2, which is expediting patient transfer to a lower level of care. Next slide. That is all the presentation that we have here today. There is more information on the Surge Line website if you'd like to see that. I think we're going to be posting some FAQs for healthcare facilities here in the next 24 hours, and then this webinar should be posted there in the next 24 hours. Any questions, though, please email surgeline@azdhs.gov. Thank you so much for your attention and your participation. We have time to